It's a pleasure to have Dr. Theoharis Theoharides with us today. As a professor of pharmacology and internal medicine, Dr. Theo has made groundbreaking contributions to our understanding of how mast cells influence chronic pain and inflammatory conditions. His research has shed light on the critical role these cells play in pelvic pain, bladder disorders, and other pelvic health issues. So let's get to it and let the expert help us understand what mast cells are, how they impact our health, and what we can do to better manage their activation. So welcome, Dr. Theo. It's a pleasure to have you with us today. Thank you for being here.
Marnie, it's a great pleasure to be there, and I really appreciate the chance to help our listeners navigate through a field that is becoming more complex by the day, even though it's so critically important for many chronic complex disorders.
And I think, many doctors don't explain what mast cells are and how important they are in these chronic conditions. So I'm really excited to help people understand and almost like a 101 on what mast cells are. So why don't we just start off by defining what a mast cell is?
Okay. So mast cells are unique immune cells, and they do most of the time derive from the bone marrow, just like other hemopoietic cells, like what we call leukocytes or platelets or red blood cells. But unlike the other cells that circulate in the bloodstream, they show up in the bloodstream as immature cells, and then they home for tissues. And they then relocate in every tissue of the body. And unlike what we thought when I was at Yale Medical School and other medical schools, where all the mast cells are the same, they're not. Depending on which tissue they reside, they change their ability to perform their functions. We call it phenotype, depending on the microenvironmental conditions of that tissue and whatever other circumstances might be associated with that tissue. Now, we know that they are in every tissue exposed to the outside world: eyes, nose, mouth, lungs, skin, gut. So they're the first responders to something that they sense happening to outside. I was among the first to show that the mast cells exist in our brain, especially in the part of the brain that regulates emotions called amygdala, and the part of the brain that regulates pretty much how our hormones are released and how our heart beats. We call all of this homeostasis, and the organ of the body is the hypothalamus.
Mm-hmm.
The brain does not get allergic reactions. So by definition, even though we know the mast cells are involved in allergic reactions, they must be doing something else in the brain. Now, how did the mast cells get to be associated with allergies? Because that's what we teach at medical schools.
Mm-hmm.
In 1887, a German physician, Paul Ehrlich, was studying basically various tissues in animals and humans, and he was using various dyes to recognize them.
Mm-hmm.
And he used a dye called toluidine blue. It's a blue dye. But when he stained the tissue, some cells, especially the skin, turned violet. And he called that, with the Greek words, metachromasia, change of color. So when you looked a little more carefully, he saw that the violet color was in little dots inside the cells. He didn't know what those dots were. He thought that these cells were feeding surrounding cells, and he used the Greek word from breast, mastos, like mastectomy, and he called them mast cells because he thought that they were feeding like the breast feeds the baby. Well, as it turns out, the mast cells don't feed anything, but the term actually remained, unfortunately.
Hmm.
And at that time, two scientists, French scientists, were working out of the Oceanographic Museum of the Principality of Monaco,
Mm-hmm.
and they were doing an experiment where they took jellyfish tentacles, they ground them up, they injected them into dogs, and they thought the dogs were going to be prophylaxed from subsequent stings by the jellyfish. So they had a word ready for it. They were going to call the phenomenon prophylaxis. Well, instead, the dogs dropped the blood pressure, the bronchi constricted, and they died. So they called it anaphylaxis. So the
Mm-hmm.
term anaphylaxis, which is 100% dependent on mast cells, And the identification of the mast cells happened about the same time, around 1900. But it was not until 1947, when histamine was discovered in mast cells, that the mast cells were associated with allergies. Now, think of the mast cell as a soccer ball filled with about 1,000 ping pong balls. These are the secretory granules, and each granule has about 50 pre-stored molecules inside. And when the mast cell is activated, let's say in an anaphylactic reaction, it explodes like a hand grenade and releases all those 50 molecules, one of which is histamine. But over a period of 6 hours, it creates another 300 or so additional molecules that have nothing to do with histamine. So sometimes we call this the late phase reaction. So we have to, and I'll stop with this, keep in mind that the immediate release that associate the mast cells to allergies involves release of histamine, maybe prostaglandins, leukotrienes, something called platelet activating factor. All the other molecules that are pro-inflammatory are released a little later. And unfortunately, there is no specific molecule only to the mast cell, except for histamine and an enzyme called tryptase. This is why pretty much everybody is looking to measure histamine and tryptase as a reflection of mast cell activation. However, as I indicated, histamine and tryptase are inside the granules. So mast cells may not release histamine and tryptase if we're looking at late phase release of molecules. And in addition, many triggers such as stress, such as bacteria, such as viruses, such as mold, stimulate the mast cells to release pro-inflammatory molecules without ever releasing tryptase or histamine. So I gave you a sort of a complicated picture of the mast cells are like, and we can return to it as our conversation progresses.
Yeah, no, that's fascinating. I mean, I never had such a complex but yet simplified. You kind of did both there and made it make sense. So that's great. Thank you for that. And so let's just go into mast cell activation syndrome and what it is and how it gets triggered. Because we're seeing how these mast cells are playing such an important role. And so how are people struggling here? Like, and what conditions do they bring on? And how can we manage them?
So over the years, different terms have been used to describe activation of mast cells. And unfortunately, they're becoming more confusing. So for instance, if we say an allergic reaction, that means that the mast cell responded to an allergen. An allergen will trigger the mast cells via specific antibodies called immunoglobulin E or IgE, bound to specific receptors on the surface of the mast cell. However, there are many molecules that can trigger the mast cell without going through the IgE receptor and still cause this explosion or degranulation, we call it. And we sometimes call that pseudo-allergy. And therefore, many colleagues separate the two by calling the allergic response atopic response, atopic disease, and they call everything else allergy. So by definition, atopy involves IgE, while allergy might involve other triggers. However, the mast cells may be triggered, as I said, by other stimuli, such as stress, such as viruses, etc., that are way beyond the pseudoallergy. So what do we call this now? So many years ago, my colleagues, Jem Atkin and Dean Metcalf and Peter Vallen, described a condition that they call mast cell activation syndrome. However, when they defined this, the definition was a history of allergic-like problems, improvement of at least some of the symptoms by using medications addressing at least some of the mast cell mediators, like antihistamines, for instance, and measurement of either tryptase in the blood or breakdown products of histamine, prostaglandin, leukotrienes in 24-hour urine. Okay? So you could have some of those or all of those. And for the first time, which was music to my ear, they also said that these patients had neurologic complaints. No one had ever discussed neurologic complaints. However, as things moved forward in the last 10 years, for some reason, the focus became just the measurement of tryptase. So by the typical quote-unquote definition that you see in most journals, you have to have the history of allergic problems. You have to have some improvement with, antihistamines or what have you, but you have to have tryptase elevated in the blood within 48 hours of an episode. Now, this created a serious problem, at least in my mind. Number one, there are numerous patients that have all the others, but no tryptase elevation. Number two, unless you have an indwelling catheter, no one can draw blood within like a day or so. And if you go to an emergency room, they probably don't know what you're talking about. Now, given the fact that for many patients, there's no tryptase elevation, or they cannot measure it in time because of practical, problems, what do you do? Well, there's another group of people, including Dr. Moldering in Germany and Dr. Afrin in New York, that they believe that the clinical presentation is the most important one, to call it mast cell activation syndrome. So there's a dichotomy. So either we measure tryptase or we don't measure tryptase. What are the pluses and minuses, and where do I stand? If you do measure tryptase, clearly that defines it because you have all the other symptoms, et cetera, et cetera. But if you don't, what do you tell these patients? And I tell these patients that the international diagnostic codes that are adhered to in Canada as well have different code for mast cell activation syndrome, a different code for mast cell activation unspecified, where there's no tryptase elevation, and then another code for mast cell activation disorders. So I told patients and my colleagues, just choose one of the other codes, because at the end of the day, the way we approach treatment of these conditions is the same, whether tryptase is high or not. And many colleagues believe that elevation of tryptase indicates mast cell burden and not so much activation. In other words, let's say that you and I have 10 mast cells. If you have 100 mast cells, tryptase will be high because it is released without activation all the time. So that reflects the number of mast cells. But let's say now that you don't have the 100 mast cells, in which case you would have had mastocytosis, but you have, let's say, 5 mast cells, but they're firing like crazy. Well, that's what mast cell activation is. And therefore, we should just focus on the fact that mast cells could be activated and what they do, and not necessarily call it MCAS or mast cell activation syndrome, because people get stuck up about what it is and, am I going to treat it differently? If I don't have it, what does that mean? Unfortunately, it doesn't mean very much because, as we will discuss later, the treatment approach is pretty much the same. Now, the only thing the high tryptase might indicate, if we measure it, if it is very high, then I have to think, could this patient have systemic mastocytosis, in which case I might be not forced, but might have to actually think of other things to do. So right now, it used to be that the cutoff was 11.5 nanograms per milliliter in the blood. Then it became 15. Now people are talking about 20. So, by raising the bar, it makes it almost impossible for someone to have mast cell activation syndrome because that's a very high level. Now, if someone has chronically very high level of tryptase, I have to find out if the liver is enlarged because there may be mast cells accumulating, if the spleen is enlarged, because mast cells are being drawn or multiplying there, and then 2 other organs where it is very difficult to find out. One is the gastrointestinal tract, because we don't know where to biopsy, and the other is bladder. If any of those organs is actually enlarged, then we'll probably have to do a bone marrow biopsy to find out if there's proliferation of mast cells from the bone marrow. So I saw, for instance, a young lady a few months ago here in Florida. They had very difficult problems with, sleep and, balance, et cetera, and she had some of the symptoms of, mast cell activation.
Mhm.
But for some reason, the family wanted to believe that this is mast cell activation syndrome and nothing else. And I tried to convince them, unfortunately I didn't, that all eggs don't fall in one basket. That one may have comorbidities, and sleep problems might be due to all kinds of reasons. And as it turned out, this particular individual was on 5 drugs for other reasons, and all the drugs said insomnia is a side effect. So was it the mast cell that was causing the insomnia? Sure, they could have contributed, but unless and until I eliminate all the other possibilities, I don't know, what to really address.
Mhm.
And unfortunately, many of our colleagues address symptoms and not the underlying problem. And symptoms can cause, when you address symptoms, you keep on adding drugs. And statistics have said, after about 50 years, we add one disease per 5 years. For every disease, condition, disorder, whatever. For every such disorder, we prescribe at least 2 drugs or supplements. For every 2 drugs or supplements, we have 25% chance of drug interactions. So by the time you're 60, you're more likely to suffer from drug interactions rather than from the symptoms or the underlying problems we started addressing. So you really need someone to be looking at the whole person, to looking at all the symptoms, try to exclude possibilities that might be more addressable than others. Even though I'm a professor of pharmacology, use the least number of drugs that you could, if possible, and then see what is left. Because you might be able to actually improve, 80% of the symptoms, and 20% might be due to another cause. And then we'll address that cause.
What about the interaction with the nervous system? And what role would that play in pain and hypersensitivity?
But that's absolutely fascinating. And this is one of the reasons why, after 35 years in Boston, I moved to Florida, because I and my colleagues set up a center for excellence for studying neuroinflammatory sort of conditions. I said earlier the mast cells are around blood vessels. However, they're also juxtaposed to nerves, especially sensory nerves. We've known that for years. We were not the first ones to report on that. And we call that neuro-immune interactions. Well, what do you know? Every week now there is a review on neuroimmune interactions in excellent journals like Lancet and Nature and New England Journal of Medicine, what have you. So we're recognizing more and more, as I said earlier, that cells don't live in isolation. They live, in a milieu make out from different types of cells. So we and others have shown that the mast cell releases molecules that activate sensory neurons. In fact, I'm one of the keynote speakers, along with my colleague Norman Marcus from New York, to talk about mast cells and pain. And the International Society of the Study of Pain, if you go to their website, has a little video podcast of mine about the role of mast cells in pain. I published last year with colleagues a review on the role of mast cells in fibromyalgia, which is a painful condition in the muscles, not the joints. Okay? So the mast cells contain at least 10 molecules that I know, and there may be many more, that can activate neurons. So histamine will stimulate neurons. A wonderful paper was published in the journal Nature about 5 years ago, and then it was picked up in the New England Journal of Medicine as an editorial, showing that histamine released in the gut will sensitize neurons in the gut, and the sensation will be abdominal pain. And that is absolutely true with what we call colicky pain in children that are, for instance, sensitive or allergic to cow's milk, etc. And we used to say, well, it's colicky pain. Well, it's because they had an allergy or sensitivity to milk or certain foods. The same thing, I believe 100% happens in the bladder. Now, in the brain, it's a little trickier because the mast cells hug the blood-brain barrier, which prevents anything from getting into the brain. As you know, even circulating white blood cells don't get into the brain. If they get into the brain, they will recognize it as foreign. They will attack it. The first thing they attack is myelin, which is the sheath covering the nerves, and that's how you get multiple sclerosis.
Mm.
So the mast cells, when they're activated, they open up the blood-brain barrier, and now they allow molecules that shouldn't get into the brain to get into the brain. And what happens is they activate the brain defenders, the microglia. So think of the brain as filled with spiders, and the spider web is the scaffolding onto which the neurons crawl and make connections. If the microglia get stimulated, they stop making the connections. So now the connectivity goes down, and they start attacking the invader, and they release inflammatory molecules on their own right and causes a localized inflammation. So stimulating the mast cells can be very damaging in many different ways, but certainly pain. So going back, not only histamine, prostaglandins that are released from mast cells, bradykinin released from mast cells, nerve growth factor released from mast cells, and many, many other such molecules. So we do not have drugs to block those molecules. I mean, we have a drug that blocks the leukotrienes called Singular, and then we use it in asthma, but we don't really use it in other conditions. There's some drugs, such as cromolyn, for instance, we will talk about this later, that are supposed to be mast cell blockers, but they really don't block mast cells very well at all. And they're absorbed less than 5% from the gut.
Mm.
So, for instance, Singular was used in interstitial cystitis, no result, no improvement. Cromolyn was used in interstitial cystitis, zero improvement. And I'll explain later why there was no improvement. But linking it to what I've already said is because they really don't block the mast cells. They might be blocking part of the mechanism, which is not actually prevalent in many of the conditions, including, interstitial cystitis.
So we've only figured out really how to block histamine. And
Correct. And
Hmm.
leukotrienes, so that's about it.
Wow.
And in all honesty, we cannot go after every single mediator coming from the mast cells. As I said, there are about 350 of them. Recently, a number of biologics were developed, and by biologic we mean antibodies, against some of the molecules that either involve the mast cells or involve some of the mediators. So they went after interleukin-5, which stimulates eosinophils. So for late asthma, late pruritus or itching that don't do well with antihistamines, those molecules seem to be very helpful, but they don't touch the mast cells. Again, they're involved in some of the outside the mast cells interactions. And I've spent 40 years of my life trying to regulate the mast cells. And I hate the word block the mast cells because at the end of the day, I don't want to block the mast cells necessarily, or at least eliminate them, because some of the biologics used for mastocytosis will eliminate the mast cells. And for good reason, because you might have a very aggressive disease. But to give you an example, mast cells have existed for almost 300 million years. There are mast cells in invertebrates. Fish, lizards have mast cells. They don't get allergic reactions. And we believe that the mast cells back then and until recently played the role of all our systems because those animal species do not have developed systems. There was no separate nervous system, separate hormonal system, separate immune system. So the mast cell with a plethora of mediators in the granules could potentially play all of those roles at some point or another. And as we develop systems, they kind of, were left by the wayside. And as we unfortunately were dumping in our environment so many triggers, now they actually get triggered. Give you two positive actions of a mast cell. Let's say you're bitten, by a wasp, or you're bitten by a scorpion. I'm just giving an example. The mast cells, within seconds, will release what I call meat tenderizing enzymes. Tryptase is one of them, and they will destroy the toxin. No question about it. If that happens and it stops, it's wonderful. But if it doesn't stop, Now you will have tryptase being released all the time and it will cause inflammation.
Mhm.
Give you another example. When we have a wound, we create something happened, we hurt ourselves. We have an open wound. The wound will go through three phases before it closes. The first phase is to get rid of the debris. The mast cells do that. The second phase is to cause new cells to come in and fill in the wound. We call that angiogenesis. The mast cells do that. And then eventually you will create a keloid fibrosis to protect the wound. The mast cells do that. So the mast cells in a wound know what to do and how to do it and when to do it. I wish I could tell the mast cells to do what I want them to do. I cannot. Okay? So that's why I tend to say I would love to regulate the mast cell and not necessarily, block it.
Mhm.
And some of the molecules we'll talk about later could regulate the mast cell to some extent, but not to the extent that I would like to.
So we're seeing hypersensitivity more now than ever before. And we're seeing conditions, chronic conditions like interstitial cystitis, endometriosis. So would you say these patients are experiencing MCAS, mast cell activation syndrome,
Well,
along?
what I can tell you is that they certainly have activation of mast cells in those tissues. No question about it. I've published this numerous times as far back as 30 years ago,
Mhm.
and this being repeated by other colleagues.
Mhm.
But if there is activation of mast cells in an organ, what do we call it? So let's say that it's activation of mast cells only in the gut.
Mhm.
Well, I might call it gastrointestinal mastocytosis, or mast cell activation in the gut.
Right.
In the bladder, the European urologists do biopsy the detrusor muscle. In the States, hardly anybody does it anymore. And they do count mast cells. And in fact, increased number of mast cells in the detrusor muscle is part of the diagnosis of interstitial cystitis in Europe. We don't do it
Interesting.
here. Yeah, it might be a subgroup of patients. But as I said already today, the number of mast cells is not what I'm interested in, is the activation of the mast cells.
Mhm.
And therefore, we should be measuring mediators of mast cell in the urine. Now, we and others measured high histamine in the urine.
Mhm.
No one has measured tryptase in the urine of interstitial cystitis patients. And there are a number of other molecules that we now measure. So one of the things I wanted to ask my colleagues in urology is whether we can actually measure this new panel of muscle mediators that I've developed that no one has measured as of yet in the urine of interstitial cystitis patients. However, we published two papers over 25 years ago where colleagues biopsied in the same patient endometrial lesions and bladder lesions. It just so happened that these patients had both. And
Mhm.
we look for mast cell activation and we look for inflammation, and the results were identical to the
Mhm.
extent that we measured both in the endometriosis lesions and in the bladder lesions. So from that point of view, I must say that there's a common denominator. Now, if these patients had also itching and flushing and diarrhea, then yes, now you feed into the well-known mast cell activation disorder or mast cell activation, syndrome, etc. But many patients don't have itching and flushing. So what do we call them now? That's why I would like to reserve the terms tissue mast cell activation
Mhm.
or tissue mastocytosis if the mast cells are also high in number, in which case we could have bladder mastocytosis, as we do have when our colleagues in Europe count the mast cells, or bladder mast cell activation disorder. I would call it a syndrome because I don't know if tryptase is high, and most of the time tryptase is not high in the blood.
Mhm.
But I still know what is happening in this patient, so I've got to call it something. And that's what I would do. I would call it mast cell activation disorder rather than syndrome.
Mhm. What's interesting is when you look at, phenotypes of IC, there's the hypersensitivity phenotype. And I wonder if, people who are struggling with the mast cells would fall under this. I would assume that they would fall under this category if they're
Marnie,
hypersensitive.
this is the first thing that got me into studying interstitial cystitis almost 30 years ago. I
Mhm.
was at one of the very first meetings. Unfortunately, some of the people that were at that meeting either are not with us anymore or are not involved anymore. But it was obvious to me that about 60+% of the people had symptoms that I would call back then allergic symptoms. Now we call them hypersensitivity. And this is why among the first things I recommended back then, and then we did clinical studies involving that, was the antihistamine hydroxyzine.
Mm.
Because hydroxyzine or Atarax, at
Mhm.
least one of the trade names, is both an antihistamine and it's slightly anti-anxiety. And we know anybody with chronic problems is likely to be anxious. And it's a little sedating, so it might cut down on nocturia as well.
Mm.
So anything else we will talk about, I always say you should be taking some hydroxyzine at night. Now, some people are a little more sensitive than others, so I usually recommend between 10 and 25 milligrams at night, no more than that, because many of my colleagues think that if we give more, it will be better. And sometimes in mast cell activation disorders, including mastocytosis, the recommendation is 4 times the initial recommended dose. But what happens is all antihistamines are also anticholinergic, and the cholinergic system stimulates the bladder to urinate. So I've had patients that were put on 4 times the recommended dose and they went into retention. They couldn't urinate anymore. They went to the other extreme. So we've got to be careful and be cognizant of the side effects or other actions of such molecules. But nevertheless, hydroxyzine is definitely in my list, especially when it comes to bladder-related problems.
And then we also have to look at the long-term effects of the cognitive decline that it could cause.
True, true. Well, that is an issue that is being debated, and I wrote an editorial almost 20 years ago about this, and now it's resurfacing again. There was a paper that was published back then, and I wrote an editorial about it, where they looked at elderly people who were taking basically the first generation antihistamines. Those are the ones that are sedating, like Atarax, like Benadryl, for instance. And yes, there was an association with worse dementia, but they already had dementia, or at least the beginnings of dementia,
Mm.
and they were taking it for over 6 months at very high dosages. So
Mhm.
if dosage is below 25 milligrams, I wouldn't worry about it.
I wanted to know if you can sort of let us know what some promising treatments or strategies for calming overactive mast cells would be.
Sure.
Yeah.
What I'm about to tell you holds true whether it's the bladder, the skin, whether it's muscle activation syndrome or mastocytosis, with some caveats that I'll explain as I go through it. So let's assume that there is hypersensitivity of the mast cells to whatever there. And many times we don't know what the trigger is. Okay?
Mhm.
So we'll address it as hypersensitivity in the bladder, as it might be in the skin or the gut, etc. So if the history is telling me that, then I've got to know if the mast cells are firing regardless of what the trigger is. And the first thing I will do is the scratch test. If you look at my arm, I will just basically with one finger, hopefully with short nails so you don't break your nails, just do a continuous scratch from the elbow to the wrist like this and wait for about a minute or two. If this line turns red, that means that the mast cells in the skin fire just to my pressure,
Hmm.
pressure of the finger. There's no allergen there. There's nothing else. There's no bacteria. And we call that dermatographia from the Greek. That means that you can write on your skin. And invariably, most of the people that have mast cell related problems, if not 100% of them, they will turn red. And in about 2 minutes, the redness will disappear. If that happens, I've got to now chase down why the mast cells are firing. And there are a number of tests that we do, not only in the bladder, just in the blood as well. So we will measure total immunoglobulin E. We will measure subclasses of immunoglobulin G, especially IgG4, because that indicates sensitivities, not allergies. And I will measure a number of mediators over and beyond, tryptase, etc. And I will do an allergy panel and I will do a sensitivity panel because, as I said, the allergy is IgE, the sensitivity panel is IgG4. And that will allow me to identify triggers because in my mind, the first thing we have to eliminate is the triggers. And we have found over the years, and I was lecturing on this 20 years ago, that the triggers are similar triggers to the triggers that cause migraine headaches.
Mm-hmm.
And in fact, many of the patients with interstitial cystitis or sensitivities do get headaches.
Mm-hmm.
So the first thing to eliminate would be foods rich in histamine.
Mm-hmm.
And that would be cheese, avocado, tomatoes, spinach, sardines, and all spices. Pineapple has a lot of histamine too. Spices like cumin and cinnamon has a lot of histamine. You give an example. I would avoid fermented foods, especially wines and beers because they're fermented.
Mm-hmm.
And if you were to cook something, especially if you don't cook it very well,
mm-hmm.
and you leave it in the refrigerator, not freezer, and you now recook it, that will allow actually histamine and other molecules to show up as well.
Mm-hmm.
So I usually say if you're gonna eat something again, just freeze it and then cook it quickly. Don't let it warm up slowly.
Mm-hmm.
There are other, in addition to all the disorders of mast cells we discussed, there's also histamine intolerance. So histamine can come from the mast cells and also a circulating counterpart of the mast cells called the basophil, but also from foods that I just described. Now, histamine is destroyed in the gut primarily by an enzyme called diamine oxidase, DAO. We can do now gene analysis for enzymes that break down histamine. One is DAO, the other is histamine methyltransferase. And all of these enzymes in their genes could have mutations. We call them polymorphisms. So they don't make enough or they don't make enough active enzyme.
Mm-hmm.
And then you cannot break down histamine, regardless of where the histamine is coming from. Luckily, there are supplements with DAO that one can use about 15 minutes before food. But there are two caveats about this. 99% of them come actually from pork kidneys, and many ethnic and religious groups cannot do pork. So that's one problem. There's only one that is from bean sprouts. Mm-hmm. The other is that all of them except for one are not enteric coated. So a passage through the stomach, the acid of the stomach will destroy the enzymes. And that's why there's a lot of variability when people take these. Be it as it may, however, we will add DAO if someone turns out to be sensitive and or are eating foods that are rich in histamine. That's number one. Now, we will give an antihistamine because we know histamine is released, and it might not be broken down quickly whether you take a supplement or not. And as you know, there are many antihistamines, about 10 different ones. All the antihistamines do not have the same properties. So for instance, an antihistamine that exists in Canada but not in the United States is called rupatadine, and it is sold under the name of Rupall, but it's not over the counter, it's prescription. But it's got two additional benefits. It's a mild mast cell inhibitor, and it blocks also platelet activating factor that itself is involved in allergies. And platelet activating factor stimulates eosinophils, which are involved in allergies. So now you get a third benefit. So 3 birds with 1 stone. Yeah. So if I were to select, you can try with one of the typicals right at the beginning, but if it doesn't work, you've got to change the antihistamine. Don't give up and try for ones that might have additional benefits. Mm. Anybody who has a chronic problem is likely to be putting a lot of acid in their stomach because stress stimulates acid production. So we need a histamine 2 blocker. So histamine 1 would be, Zyrtec, Benadryl, Atarax, etc. The histamine 2 would be something like Pepcid, for instance. Okay? So you need to put a histamine 2 blocker as well. So those are the beginning. Avoid the triggers once we identify them or you suspect them. Start with a histamine 1 blocker, histamine 2 blocker. You can alternate until you find the right one for you. Some are sedating, some are not sedating. And then try to block the mast cells along with everything else. So the only drug available on the market that I mentioned earlier, it's cromolyn or cromolyn sodium. But cromolyn, as I said, doesn't get absorbed more than 5% from the gut. So if someone has primarily gut problems, most likely it will help to some extent, and I'm all for it. But since it doesn't get absorbed, it's not going to help elsewhere in the body unless molecules released in the gut, such as histamine, of course, may be absorbed and they might have systemic effects. But the benefit will be from blocking the mast cells in the gut.
Right.
However, the body gets used to cromolyn very quickly. So we start with 100 milligrams once a day, then 400 milligrams a day, then 400 milligrams 4 times a day. But the time you reach that level, cromolyn is not going to work anymore.
Mm.
And in addition, once you reach that level, about 15% of people get diarrhea, and about 5% of the people start losing their hair. So it's not an innocuous molecule, even though people might think so. However, if someone has allergic rhinitis, then cromolyn exists as nasal chrome. You can spray it in the nose, and that works fairly well for allergic rhinitis. But we started studying the structure of cromolyn almost 20 years ago. And in fact, I'll take credit. One of my first publications in the journal Science, when I was still a graduate student at Yale, because I did both my medical degree and my doctorate degree at Yale, was actually how cromolyn may work. So we published that back in 1978, in an example. But it worked like a charm in mast cells from rats. Over the years, Dr. Steve Galli from Stanford showed that it's actually less active in mice. And then Dr. Church from England and others and we showed that it's very, very weak inhibitor of mast cells, especially the pro-inflammatory molecules. So we published a paper 2 years ago using human cultured mast cells in the laboratory, and we stimulate them with various triggers, some through IG, some not, and we pre-treated with equal amounts of either cromolyn or the natural molecule luteolin and the natural molecule quercetin that I will talk about shortly. And we showed that both were better inhibitors of cromolyn, of everything that the mast cell could release. But they're not drugs, and physicians like drugs. They don't like natural molecules. So almost 20 years ago, we created a supplement that was called, and is still called, Cystoprotect, with a K at the end. And I helped a company called Algonaut in Sarasota, Florida, make it. It included actually, and it still does, 4 ingredients. It includes quercetin, which is anti-inflammatory and mast cell blocker. It includes a little bit of rutin, because rutin allows liberation of quercetin over time, so slowly liberating it. It includes the 2 molecules well known to protect the bladder lining, which is hyaluronic acid. Forget the word acid, it's hyaluronate basically, and chondroitin sulfate. And because all of those are not absorbed very well from the intestine, they were mixed with olive pomace oil. So olive oil, we usually like the virgin olive oil because it is polyphenolic. And the more phenols you have, the more antioxidant you are. However, we and others have shown, and we had a paper published last year on the anti-inflammatory activity of components in olive oil. The more antioxidant you are, the less anti-inflammatory you are. So we wanted to have a balance, basically, the two. And we used olive pomace oil. So after you take the olive oil, you're left with a pitch. If you crush the pitch, you get another oil, which is not polyphenolic, and it's actually cheaper than olive oil. But that allows you to create small spheres called liposomes that increase absorption from the gut about 3 to 5 times. So that way, we were reducing the inflammation that was causing the damage. while allowing the body to replenish the bladder lining at the same time.
Mm.
And you were getting basically the benefits of Mediterranean diet in a capsule as well because of the olive pomace oil.
Yeah.
Now, that has been used for more than 20 years, and it's still being used. And during the course of these years, a drug was approved by the FDA in the United States called Elmiron, based on a study that was never replicated, by the way. And over the last 2 years or so, numerous reports have come out that have been using Elmiron for like 3 to 6 months. You go blind. And now there are all kind of class action suits against the company, etc. So can we do any better than the Sister Protect? So remember, we said antihistamines, probably Atarax at night. We can increase the amount, but not too much. Give a type 2 blocker like Pepsid. Use the Sister Protect. But now, as I said, we've shown that luteolin, which is very similar to cromolyn, is better than cromolyn and it's better than quercetin as well. So now we have an additional supplement called Pure Lute that is 100% luteolin. So we can add the Pure Lute to the Sister Protect. So that way we can get, additional benefit. And to the extent that there is continuous pain, I recommend a natural molecule called alpha lipoic acid, about 500 milligrams per day, because it's been shown by numerous studies by other colleagues that it reduces what we call peripheral neuropathy, pain that is in the periphery, including the bladder. So that is my original approach, and I usually give it 3 to 6 months. And then, we kind of see what symptoms improved, what symptoms, if any, might be remaining. If there is associated gastrointestinal problems, then I usually recommend butyrate. Butyrate is made by good bacteria in the gut. They're called short-term fatty acids. But butyrate has also been shown to inhibit mast cells. So if there's GI-associated problems, I will use that. And to the extent that I need to rebalance the microbiome, I recommend bifidobacteria probiotics because the bifidobacteria actually reduce histamine levels. And there are 3 that have been shown to be better than others. One is called brevis, one is called infantis, the other is called longum. But it doesn't really matter. Studies have shown that if you have, the more species you have of these good bacteria, and the more you have, the better. So I usually try to go for 5 to 10 different species and 50 billion microorganisms. And that will happen regardless, whether you have GI problems or not.
Now let me benefit from probiotics. Absolutely.
Yeah, let me take a deep breath and you go back and ask.
Yeah, no, the wealth, you are a wealth of knowledge. It's unbelievable when we have these discussions, how much I learn, and it's just fascinating how much information you have in your brain.
Marnie, I have to say, I've learned so much from patients themselves.
Yeah.
I'll give you an example. There was one patient that I was helping a lot over the years. And in fact, she and I traveled the world and gave lectures on people that had mast cell activation and such symptoms. And one of the things she had told me back then, from what I know, because I haven't been in touch recently, she continues to do well. But she had told me that vitamin D3 was helping her. That was about, 10, 15 years ago. And I said, vitamin D3? I mean, come on. And yet, when I started studying it, there was a lot of truth to it. I actually, I was an editor for a whole volume in the journal Clinical Therapeutics on the immune effects of vitamin D3. And as it turns out, about 40% of the people, regardless of sunshine, whether it's Greece, Florida, California, etc., do lack vitamin D3.
Yeah.
And therefore, we have to supplement it. So invariably, I would recommend at least 2,000 units a day, if not 5,000 units a day of vitamin D3 for the period, again, 3 to 6 months, and then we can measure levels and keep on going.
So
Now,
true.
many of individuals that have such problems, and we kind of basically spoke about endometriosis and bladder problems, but individuals with mast cell activation in general, wherever it is, do have what they call brain fog. They cannot, multitask. They find it difficult to find the right words. They get flustered sometimes. And for that, all of what we discuss will improve the cognitive function. But we created a supplement called Brain Gain that helps enormously over and beyond the Cystoprotect and the Pure Lut. Again, all of those are sold by Algonaut, but you can find them on Amazon as well. The Brain Gain contains 5 ingredients. It contains the luteolin that will cut down inflammation in the brain and elsewhere, but it contains also calcium folinate or folinic acid, which I call sometimes high octane gas for the brain. So it bypasses other problems and it helps the brain. Leucovorin exists as generic. One doesn't have to take leucovorin, except that over 2 milligrams, it becomes a prescription. But let's say Brain Gain has 0.5 milligram of calcium folinate, and my recommendation is 2 capsules twice a day. So you'll be getting about 2.5 milligrams a day anyhow.
Perfect.
It contains also phosphatidylserine, which is an important ingredient of the membranes of the nerves, of the neurons, of the brain cells. Okay? And it contains biotin as well as selenium, and it contains hydroxytyrosol, which is from olive tree leaves, that is very antioxidant. But all of those are mixed again in olive pomace oil. And why do I stress that again? Not only it increases the absorption, but as you know, olive oil is very rich in monounsaturated fatty acids, especially linoleic acid. Okay? And both linoleic acid and phosphatidylserine are plasmalogens. I don't know if you've heard the word plasmalogens. It's a buzzword these days, because plasmalogens are part of the surface of the brain cells that allows them to withstand basically damage from the outside. It's like you're fortifying your membrane. So many companies out there now sell plasmalogens, but if you look at what they are, they're phosphatidylserine and linoleic acid. Well, Brain Gain already has them. So Brain Gain is 2 plasmalogens, has got folinic acid or calcium folinate, it's got hydroxytyrosol, it's got actually already luteolin, which we discussed, it's anti-inflammatory, it's antihistaminic, and it's got 2 vitamins as well. Well, you've got 7 birds with 1 stone, if I'm allowed to say that.
Wow. I just wanted to quickly bring up the conference taking place in Milan,
Yes.
October 23rd to the 25th.
So I'm speaking at 2:00 on mast cell dysfunction, local and peripheral roles in ICPBS. I have to give credit to Dr. Moldwin because he published a couple of papers, which of course was again music to my ears, that many of the patients with interstitial cystitis are very sensitive to foods. And of course, as I said throughout our presentation today, in fact, they are. And removing or eliminating such triggers should be part of how we should be addressing this issue. And I'm glad he's championing it, even though he doesn't address mast cells as such, but indirectly, the mast cells are the problem. So, I do have a simplified website, which is drtheoharides.com. So there are a lot of papers uploaded. There are a lot of podcasts uploaded. With your permission, I might upload yours at some point as well.
Right.
And there are also rubrics, such as the one that I just discussed, in terms of how I think through things. And that is a link to other things as well. So that might be kind of useful. And then, as you know, I do have an Instagram account, which is at Theoharides. And almost every week now, I try to put a post, sometimes in response to questions that come from your listeners and other listeners. I try to make them, most of it in terms of explain it if I can, or make sure that people don't misrepresent facts, out there that might confuse kind of the public. And to the extent that anybody is quote unquote, and I hate the word desperate, but every third week of the month, on Tuesdays or Wednesdays, I do see patients with complex sort of inflammatory diseases at our site in Fort Lauderdale. So I'm a professor now at Nova Southeastern University. So I have a lab with about 4 people there. And I have 2 wonderful nurse practitioners, each one of which has a doctorate in integrative medicine. And we see patients together.
That's
So
great.
if anybody is desperate, they can reach out either to
Yes.
me or to that group, and kind of they can take it from there. And by the way, as you know, there are a lot of Canadian families that come to Florida for vacation.
Yes,
So they might actually kind of get 2 things done.
absolutely.
To the extent that you might want to actually mention it, the number for making appointments is 954-262-2850. 954-262-2850.
Okay. That's great. I'm going to put that also in the comment section. So we'll have all the information. So if anyone didn't catch that, I will make sure that you have it accessible to you. Thank you
Excellent.
so much, Dr. Theo.
Stay well.
You too.